My name is Jill Wadnick. I work on improving maternity care at Montclair State University, where I'm also a childbirth educator and a birth doula and a birth doula trainer. So thank you for having me.
I'll ditto that, thank you. And thank you for those of you that were able to stay. My name is Robin Dioria. I'm an advanced practice nurse. I serve and have the privilege of being the CEO of Central Jersey Family Health Consortium, which is one of the 3 maternal child health consortia within the state of New Jersey. Our role is to provide public health initiatives in this maternal child health space.
And good morning, nearly afternoon. I'm Helen Hannigan. I am Robin's corollary in South Jersey, so we're delighted to have so many of our South Jersey partners here, and I'm really proud to have so many members of my team join us. We're really delighted to share with ACNJ so many of the initiatives that support mothers in order to support healthy kids. In South Jersey, we focus a lot of our programs on interventions with our hospitals as well as with the community, as Robin mentioned, to be sure that our physicians and training nurses and social workers, as well as our community health workers, are aligned and aware of what the community's needs are and responsive. So we're delighted to partner with so many, and happy to be with everybody on stage.
Absolutely. Good morning, and thank you again. It just sounds so redundant. But thank you for having me. I'm Marie Carl Vilcius-Talty. I'm the president and CEO for the Partnership for Maternal and Child Health of Northern New Jersey, one of the 3 consortia. I know why my name is a little longer, but we do very similar things. So I cover the 8 counties of Northern New Jersey, ensuring the same thing that Robin and Helen do. We want to make sure that we are part of the community, making sure that the community's voices are heard, that we work collaboratively with all of our subgrantees, and making sure that the voices that are needed are at the table. So thank you so much for having me.
Maybe before we get started, because I'm lucky to know every single person on this stage, as we were talking about the discussion, maybe we can go one by one. What do you think is a challenge that maybe we didn't mention during the conversation? I'm thinking a little bit, maybe, Jill, around midwifery, for example. We're spending a little more time on that.
Sure, yeah. So that's a great conversation about midwifery, and that's one of the policy areas I work on. New Jersey does not have what's called the adequate number of midwives for our workforce. And so level setting that from a workforce perspective, we really need skilled maternity care specialists in all of the domains and all of the different levels of care. And the midwifery model of care is a unique model. And so New Jersey has 3 credentials for midwifery practice. We have CNM, CM, and CPM. And so that is a little bit of a patchwork, but all of those credentials are licensed in New Jersey. And so that licensed healthcare provider works to the scope of their care as midwives. And so what we don't have in New Jersey is the capacity of the workforce. We don't have a retained, diverse midwifery workforce. And that's a whole other, it's a future webinar. Be happy to explain it. But we have some barriers we don't have independent practice in New Jersey, and we don't have an independent board of midwifery. And those are evidence-based pillars that other states have as part of a workforce capacity. So we have needs in New Jersey that can be very specific about a workforce retention specific to midwifery.
I could talk for the next hour on this. But one of the things I don't think we touched on this morning was before prenatal care. How women are coming into pregnancy, their health and wellness prior to getting pregnant. That very much dictates the course of their pregnancy. It can exacerbate underlying chronic issues, or those issues can arise during pregnancy. So even though we are playing a focus, and I am incredibly pleased and happy that we're able to highlight maternal health, particularly in this last administration, we need to think even more on the preconceptual health of moms. We know, and Dr. Harris explained very clearly, when maternal mortality or death occurs and morbidity or severe illness occurs. The majority of maternal deaths in New Jersey is well over 60% in the postpartum period. Much of that, again, we could talk for an hour about what that is, but if you come into pregnancy not being of the best health, those underlying issues not only can become more apparent during pregnancy, but continue to wreak havoc after that, within that first year. So I do think one of the issues we need to add on to the work that's being done is the preconceptual health of childbearing age people in New Jersey.
And I absolutely concur with Jill and Robin. And I would say for South Jersey in particular, some of the issues that were raised are even a little bit more complex. So when we think about transportation, particularly in our South Jersey region, we have 2 counties with no birthing facilities and with very few prenatal options. And so what that means is there's a tremendous effort that has to be put into getting to care during pregnancy and at the point of delivery, and the systems that many individuals would rely on and that sound appropriate in central and northern New Jersey really don't meet the needs of individuals in South Jersey. So how we need to patchwork the relationships for a provider, an individual patient, and then to navigate all of the things that that family needs in order to access services become much more complex in southern New Jersey. And so I think it's just really elevating the regional differences and the community level descriptions, and when things don't resonate, when policies come forward and solutions come forward and my community doesn't feel represented, whether that's a geopolitical community in a county or a community, an ethnic or racial identity that you have, the feeling is that you're not represented, and the opportunity to engage around what we're bringing forward can be lost when we're not speaking in a way that's relevant to individuals in different communities.
Helen, I want to continue with that thought because everything that we talked about is true, the siloing and the policy making. But I think one of the things that we're missing out on a lot is we're siloing maternal health as it's just a specific issue when it's really a public health issue, right? Maternal health is public health. And we're not bringing that so much to the forefront. We're always siloing that conversation. And how do we bring people to the table? Because change happens at the rate of trust. And we can have all the policies, we can have all of these 22 different agencies working with MIA, but if the community doesn't trust us, then how are they going to be the change that is needed? So I think that's really important. And one of the things that we have been doing inside of the partnership is working on becoming an anti-racist organization. And I know we're not supposed to say those words anymore, but how do we do no harm? How do we bring the community to the table and say, okay, you are the subject matter experts. We have the resources, we can collaborate with, different other agencies and subgrantees, but are we paying you for your time when you come in and spend 3 hours with us, giving us your expertise and your experience, and we channel that expertise and experience into real policy and real change? So how do we gain the community's trust? And I know we've been working on that for so long, advocating, going to the Hill, going to Trenton, and doing all of that. But still, the paradigm is not changing because the trust is not there. So in order for us to really make real change and have that conversation, it needs to be elevated that maternal health is not a specific women's issue. It's a public health issue because one thing happens and it's a generational effect. Imagine losing your mom, never meeting her. How does that change the whole family dynamic? How does that change the neighborhood? How does that change the whole generation? So I believe that all of us working in concert to really build that trust so we can have the change is one of the things that we talk about in small groups, but we haven't had a real initiative on making that happen.
Hello again. For me, it's preeclampsia and cardiovascular disease. That has been my hill that I am going to die on. It is the leading cause of death for Black women, both during pregnancy and just in life in general. And that leads into what Robin was talking about with the preconception care. We have very little tools that can help us prevent preeclampsia, but aspirin is one of them. It's been a well-researched, easily accessible tool that we still are not getting into the hands of families. The same with blood pressure cuffs. Again, a very simple tool that could be in the hands of families that could help to prevent worsening conditions so we can identify them earlier. But I think the conception of what preeclampsia is very misunderstood, and we did a study with our families just to ask, what is preeclampsia? And everyone said it's high blood pressure during pregnancy. And that is not what preeclampsia is. It is much more of a significant, deadly disease that includes all of your organs, your brain, your liver, your kidneys. It can get to that point of seizure and death if it's not properly managed. In fact, there was a woman that was on the news most recently who died in Texas from really severe preeclampsia at 20 weeks. And was not offered an abortion. And I know we didn't talk about reproductive rights much, but I think that's a key piece. We're protected here in New Jersey, but in other states where we're seeing things worsening, that change in Roe v. Wade really is having an impact on our maternal health outcomes as well. Had she been offered an abortion, she would likely still be here today. So preeclampsia is a very insidious disease that requires our attention. It does not end because the pregnancy is over. That was really our thought is, when we delivered the baby, the risk was over. We're finding that is not true. People who have never had preeclampsia or were not diagnosed with preeclampsia during their pregnancy, it's popping up postpartum when they're home, when no one's watching. And so we really do need to create these safety nets and structures for these women to have the care that they need so that we have that continuity.
I do want to highlight.
I was just going to.
Are we all thinking like? Are you talking about universal home visiting?
Ken, before we go there, so I have the privilege of serving on the National Preeclampsia Foundation board, and as their president, one of the issues that we are trying to work with states on is, in addition to being diagnosed during pregnancy, there are actually newer technologies now coming out that include a simple blood test to share whether or not you are more at risk for preeclampsia. Here's the caveat. No insurance companies at this moment are paying for the test. Some are looking at it. It's still early, but there are more and more studies that are proving this test and a few others to be effective. Because, like we said, that is one, for us in New Jersey, a leader. Nationally, again, a leader in maternal mortality. And in most cases, 100% preventable. So it's even a bigger issue because then you have to include some of these other factors as far as how can we prevent it. But I would love to segue. No, not yet.
No, I thank you for saying this because I think one of the things that we haven't spoken about is the payment mechanisms in maternity care, and you just touched upon that in terms of a diagnostic and screening tool. But and again, these are deeper conversations, but that add to the complexity and why we need a universal collaboration and coordination. Because the financing of maternity care, Dr. Harris, the example you gave that was in the New York Times about Black women in New Jersey having more unnecessary cesarean births was not only with racism, it was coupled with the economic incentive of the payment of how maternity care delivery is financed. So all of these things are in confluence with each other.
Can I go now? Okay.
Your turn.
Of course, all of these things are interconnected, but one of the good things that is happening is universal home visiting, right? So, and I say that because when we talk about preeclampsia, specifically in Essex, the rate of preeclampsia and cardiovascular disease is about 25% higher than the rest of the state. And what happens with universal home visiting, so far we've done about 25,000 visits. 2,500, yeah. I'm thinking about next year. We're really going to do every single baby.
I was like, wow.
2,500 visits, and 17% of those visits have been interrupted so that there is an intervention where either the child or the patient, mother, the birthing person, has needed medical intervention, whether they're going back to the ER, they're going to their physician, or the baby is being seen. So that tells you that it's not only about the comorbidities and the preconceptual counseling. We need that village, right? We need people to say, no, you are not puffy or swollen because you're tired and you just had a baby. You have preeclampsia. There is a physiological issue going on that we need to be educated on, and it's not just the birthing person. And what makes this program so great is the fact that when the nurses go to the home, the significant other is there, grandma's there. It's the village that is there and says, oh, no, remember the nurse came in and she said that you needed to do 1, 2, 3, and 4. And preeclampsia is not done. Your high blood pressure episode is not done just because the baby is out. This could last for a year, and the nurse wants you to do this, this, and that. So it's all of us getting together, having all of this information, having the legislation and the policy side, and having the midwives, right? The midwives at the bedside being part of the care team, that makes it really, really important. Thank you for
I'd
bringing
love
that
to
up.
just prove how well coordinated we are without having prepared, but we also we recognize from the perspective of what our insurance companies are required to pay for in terms of blood pressure cuffs, right? That's a requirement in the same way that breast pumps are. However, access to those tools is very, very difficult. So we've coordinated and collaborated across our organizations and importantly with our provider community and other community organizations to make blood pressure cuffs a part of what we call Go Kits. We started during COVID to have blood pressure cuffs and other resources for self-management and self-care. But what we've seen and what we know is so important and much what the models that Dr. Harris is bringing forward is that connection, the belief that your care provider cares about you and that they're giving you something to help you communicate with them about the concern. That's what's been proven over and over again to make a difference in outcomes and make a difference in survival. We know in addition to maternal outcomes, prematurity is largely tied in our state to preeclampsia, to high blood pressure, and prior to pregnancy health conditions. So as we think about prematurity prevention, we think about blood pressure and we think about self-management and awareness, but really communication with the provider who will listen and who has shown you they care, and often by giving that gift and the many items that we're able to coordinate together, that's demonstrated. And so it isn't always about our programs, which are excellent. It's really how those programs elevate the trust between the patient and their care team.
And working with the community, because we refer so much to Dr. Harris's Cuff It program. So if there is someone that has a cardiovascular issue, coordinating and referring to those community organizations that are entrenched and speaking the language, especially having some cultural congruity is really important. So making sure that all of us in the room are saying, hey, it's not my program, but I have another program that can help is really important. That's how we build the trust, and that's how we have the change happen.
And with each of our programs for universal home visiting, we have been very intentional with hiring people that have come from the community of which they're serving and are reflective of the community that they're serving. And each one of us, we've been truly blessed in how that has been able to work, but it certainly adds to the trust factor. And that has made a huge difference in the work that we're doing now.
Can I ask a question? Okay, great.
We're still talking.
I could listen to you all talk all day. But I'm Becky Ofran. I'm assistant professor of public health at Montclair State University now. I've worked with most of you in other capacities. I'm the director of our new Maternal and Child Health Workforce Catalyst program. And my question is about the upcoming change in administration here in New Jersey. I know you all have been working on maternal and infant health issues through multiple administrations. So in some ways, it's like we're just going to keep doing what we're doing. But it is a big change from the Murphy administration and Nurture New Jersey and the focus that Tammy Murphy has brought. And I'm wondering what you're concerned about in that transition and what we can, like, you know, everybody who's been involved and at the table and working on it, what can we all, like, pay specific attention to in this transition? Because, you know, I'm excited about our new governor, but it'll be a change in the focus for sure. So I'm wondering, like, what are you concerned about that we can focus on?
I think for me, having been a nurse in New Jersey for over 40 years, this program, Family Connects, and its implementation statewide, which will not be statewide until 2027, is the one program that I would really fight to the end for. Because what we've seen, and Marie Carl and Helen have given you examples, we've seen the same thing. The catches of women who have been just on the border of critically ill. We had a family that was concerned. The woman ended up, we sent her to the hospital. She was in the hospital for a week. And for this particular case, it's mostly high blood pressure, preeclampsia. This was an infection that could have really had dire consequences. We've had a few with the infant as well. So, and knowing where maternal morbidity and mortality is most prevalent in that postpartum period, I don't think you can beat this program. It's not perfect, but it blends so nicely with all the other initiatives and our ability to reach the community. For me, that would be the program that I would fight hardest for.
I'm concerned that I haven't really heard that be part of the agenda yet. And I've been watching also the transition team, and I have not seen anyone that I could identify as a maternal health expert that's joining that team. So that concerns me a little bit, that it feels like it's not on the radar, it's not a high priority, nor was it on the list of the things that she mentioned for her priorities. So that concerns me. I would also just be concerned as a Black-led organization focused on Black women specifically, the language that we use and the work that we use is under attack at the moment. And so does that change how we do work in this state? Are there safety protections being put in place for us? Are there funding lines that are going to be created for us to continue to do our work? So those are the concerns that I sit with. But I know the full team hasn't been announced yet, so I'm hoping someone in this room perhaps gets picked to be on that transition team. But I hope it's a priority because I haven't seen it named as one as of yet.
One of the things that I would say we need ongoing concern and awareness about are the quality indicators. One of the things that AC&J produced at your table today looks at what are called quality indicators and things that are pretty iterative about access to VBAC, which you see as 0%. We don't have public reported data on exclusive breastfeeding on discharge that's published the way other states do. The last time it was published was 2018 in New Jersey. So, the idea of transparency and data, so we can use it to drive programming that's equitable and really mobilize for quality indicators that are going to have a real improvement in care. So I feel we need, regardless of who's in the administration, that focus and that funding to have continuity.
Oh, I was just saying that the new administration does see maternal health as a priority, and they have outreached our team already. So,
That's great news.
that's good news.
And we've got Winifred too, so she's got double hats that she wears.
Okay, so I have two things. You all are talking about the moms, I forget the word, but when I taught my classes, and you mentioned about men being in the room, that men are the other 50%. I haven't heard that anymore today. That's part of the woman's team. Mm-hmm. The other thing is, there used to be a phrase that stated, you have to do prenatal care before you conceive. Mm-hmm. I forget that was a poster. It needs to come back because when you become pregnant, you're bringing everything in your body with you. And those all impact on maternal and fetal well-being. And that's something that needs to be considered. And I also think that everything, whether it's north, central, or south, it needs to be cohesive and it needs to be the same. Every place should be doing the same for all aspects of maternal child health, including mortality. So if a woman has a stillbirth, she should be able to have bereavement on board in the institution that she's in for all patients, no matter what race. That should be for everybody, not some and not the others, as that is still practiced, unfortunately. It's got to be brought back. I don't have a hospital in my community that somebody can have a baby, so they have to go outside the community. So something to think. East Orange General no longer has maternal child health, has not since 1975. So everybody that has a baby, unless they deliver at home, they're delivering in the outer hospitals. So something to think about. Dad is the other 50% of the pregnancy. Without him, there wouldn't be one. Think about it.
You're in my backyard, and I'd love to talk to you. We're actually based in East Orange on purpose, so I would love to talk to you afterwards.
I think that's a wonderful point and something that we haven't spoken about, but we, at the partnership, we do have a fatherhood program that we work with within the community. And not only the fatherhood program, but within our doula program, we have a doula training program where we do invite fathers and men to be more visible, because we've heard a lot from the other 50% that specifically when they attend the prenatal visit or they're there as a support person, they are othered, right? And that goes back to the trust in the community. So if they see you as an interloper, and why are you here, or are you the baby daddy? Just conversations and narrative and words that are used that make you feel unwelcome, of course, that's going to be an issue. So we are attempting to change the paradigm in doing that. And for the past 4 years, the 3 consortia have been working really collaboratively to make sure that we have one voice. And of course, we serve different aspects of the community, right? We have, I don't know anything about South Jersey, and I believe there's Central Jersey. I'm from New York, so they tell me that there is.
We make her come down south sometimes.
But we have been talking a lot about what does it look like having 3 consortia with the same voice. So everything that we do quite collaboratively, and we sit down and we're attempting to move forward as one entity serving 3, specific regions. So thank you for bringing that point.
Yeah. Is it okay if I just say one other thing related to dads? So in our Camden Healthy Start program, we have something that we've just launched called Dads in the Picture, and it's been a really effective approach, and we work to collaborate with our Southern regional programs. Oftentimes the funding does drive some of the design, but then how do we, as Marie Carl was saying, distribute that knowledge, information, and strategy out to other programs? But I also want to elevate that Burke is supporting the PRAMS for Dads, so the pregnancy surveillance survey that's done for newly postpartum women and birthing people is now, there's a fatherhood component, and we'll be bringing that to New Jersey, which is really exciting. I think it'll elevate everyone's conversation about what dads are going through and where engagement would be effective, and the health issues for men who are of childbearing age as well. So I'm excited to see that come forward, and I know it'll be a really impactful conversation to join nationally for New Jersey to be a part of that.
One other program that we work very closely with, and I think is a nice example of collaborating within our community in Trenton, there is a gentleman, his name is Peter Bullock, who started a company called Dad Doula. And he actually trains dads to become doulas and beyond. I mean, it's phenomenal work. So much of what Marie Carl just shared is part of that curriculum, but it really has changed the dynamic in Trenton and is now moving outward. So with us partnering with him, we're able to bring that piece to our programs as well.
And he's come to our events, and I know Marie
Right.
Carl's as well. So again,
Share 'em.
we agree. Being cohesive and clear and consistent is incredibly important.
Good morning, everyone. Thank you. My name is Kemba, and I have my coworker Stephanie here. I just wanted to, in the case of collaborative teams, I wanted to highlight our program as well. We are part of Nurse Family Partnership, in which we work with the first-time moms. And yes, we are limited in the sense that we work with first-time moms, but we have them from before 28 weeks pregnant when we enroll them all the way to baby's second birthday. So we're out there in the community. We are helping. We get a lot of graduates that come back, and then we're like, yes, Family Connect is now one. We work in Central Jersey. I am originally from New York, so I do know that thing. But we are in Middlesex and Somerset counties, but they have the programs in all the counties as well. And yeah, we are part of the family collaborative care. So we do events, we do things for dads. We have a background in LDRP, labor, delivery, and recovery and postpartum. I still do per diem in New York hospitals. So like Dr. Harris said, I had to unlearn a lot of behaviors, and I've been here 5 years now in Nurse Family Partnership. And as a mom myself, I see it. We start pathways on preeclampsia, right, cardiac issues and things like that. So a lot of teaching in the homes, but also just humanizing people and hearing their stories. And as a labor nurse, I'm like, that was normal, but then, you know, I have to hear it. This is how it affected them. So when we go into the homes, you know, I go in and I like to teach why something, because I realize that is the power that we're taking out of from the hospital. They don't have that moment to understand why. So we get to spend that time with them, and thank goodness that we have that time with them. But yes, first-time moms, so then we need to, again, I'm a labor nurse, so I'm like, you have a doula that I can refer you to, right? You have, for your second baby or your third, Healthy Families, Family Connect. I have not heard a lot of our clients come back with Family Connect, and a lot still don't know about the program. So how else can we help, or, you know, that.
So you and I will talk before we leave today. But you're right. I think this is still a program that needs to get publicized. There are a variety of ways to get connected to the program. And even with us being, we were fortunate enough to do the pilot of the program through Burke Foundation dollars 3 years ago. And there are still people in Trenton proper, which is where that pilot started, and went out to Mercer County that didn't know. For many reasons, not the least of which trust. Who are these people coming into my home? Now we've got a whole nother layer of, you want to come to my house, to my home, where I live. So we've made accommodations to adjust that as needed, whatever makes the family comfortable, finding safe places. So it's a work in progress, but yes, it's one more example of how collaborating within the community with other community-based organizations and programs really is a key to a lot of the work we do.
I think, and you've also I'm a big fan of Nurse Family Partnership. But I think it's also important to say if that's a new phrase for you, if NFP or Nurse Family Partnership or Family Connects, it's kind of the alphabet soup sometimes. And I think connectingnj.gov is a resource that you can self-refer. So if you're working directly with families, or like I'm a doula educator, so later on this afternoon I'll be at doula training, we were making sure that our doulas have that information, that families have it, grandparents have it. So that's, I think, a takeaway for me is that the amazing people and programs that are here as we're doing systems change, we want to know the alphabet soup. We want to know, why do I keep hearing the word consortia? Because if you're in maternal health in New Jersey, you got to know the word consortia and how to find them. And so these are things that we can navigate for each other to make sure we know the plurality of programs, which is really good that we have.
So we are from La Casa de Don Pedro in Newark. and we have a Head Start, early Head Start program. We have a lot of other resources as well, but we love to work with our prenatal moms. We have a capacity of 24 at this time, but as we're seeing the data, that might need to increase because it seems like we need to provide more resources in this group. But you mentioned, Dr. Harris, something about Cuff It program, and so we want to know who would like to buy us all the cuffs for our moms and how we can get that at our program right away, how we can partner, because we understand that our community that we serve is primarily Black and brown women, and we want to make sure that we are being preventative and we are being supportive. So how can we partner there? And how can who wants to buy us some cuffs? Okay, so we have a taker at that front. We need 24.
So I want to just talk about our Cuff It program a little bit. Our Cuff It program is culturally rooted, and if you're familiar with the term Cuff It, it's Beyonce's song. I'm a big Beyonce fan. But the Cuff It program basically is not just the cuff, and I think that's really important because often people are handed a cuff and sit to go home and then figure it out. Many people aren't taught the right way to take a blood pressure, what the blood pressure values are, the things you should do before or not do before you take a blood pressure, how often to take it, et cetera, and what do these values mean. So our program is, a validated cuff because not all cuffs are created equal, and so the cuff there's a website called validate.org, I think it is, that you can check the quality of a cuff to make sure that it is going to give an accurate reading. We sit with that family and we go over with them how to do the blood pressure, and then we're monitoring the blood pressure with them and supporting them in the navigation. So where we find the biggest barrier is we're sending someone to the emergency room. They go to said emergency room and sit there because the emergency room doesn't recognize 155 over 90 as something that's alarming, because to them, 200 over 110 is the big thing that they're going to pay attention to. So a lot of our work is not just the supplies, it's the advocacy. We've had to get on the phone multiple times and call the emergency room and let them know so-and-so is in your ED, please go see them, so that care can be escalated. So the cuff is a component of it, but it's really a lot of advocacy and education, screening, who's at risk. Our belief, just because of the type of work we do, every Black woman, every pregnant woman should have a blood pressure cuff, should know how to take it, should know they're normal, should be able to recognize a change in those values. If you're taking it daily, consistently, it's very easy to pick up when the blood pressure starts to go up. Interventions can begin at that point, opposed to waiting to when we're in an emergent situation and we need to be admitted. Many families that we work with, their pathway to delivery is a high blood pressure and a C-section. They go in for a doctor's appointment, their blood pressure's up, they're immediately routed to the emergency room, which often results in a C-section. That's not how we should be delivering, and there are steps that we could be navigating before that. And again, I'll talk about aspirin. It's one of the tools that we have accessible at the moment, and there's a study that said, although physicians reported something like 80% of their families have preeclampsia, only 40% of them are actually giving aspirin. So there's a gap between what the research says we should be doing and what's happening at the clinical practice level. And so our work, that program, combines the clinical education, not just for the mother, but for the providers as well, so that we can start to close the research gap. But I'm happy to talk with you afterwards.
And it's really, I was just going to say, it's really forums like this that bring the information to the community, right? Because from research to clinical practice takes about 7 years. Mm-hmm. So if you're on top of it, then you're going to have the newest research and you're going to say, okay, this is what we're supposed to be doing, but we know that that doesn't happen. So when we leave here, what we're asking people to do is just take one fact and say, oh, did you know? Mm-hmm. This is what's going on. Do you know that we have a universal home visiting program, that we have NFP? And when people say, what is that? They can Google, one of our names is going to come up, right? And that information will then be proliferated out into the community because it's really about education and empowerment.
Okay, I'm going to take one more question. Somebody raised their hand because it is 11.
So right before she answers that, I cannot go. This is educational session without sharing. We've talked a lot about preeclampsia, as we should. And like Dr. Harris, it's a near and dear to my heart issue. Please be aware, if you have a family member, if you know someone who has experienced preeclampsia or high blood pressure in pregnancy, even if they do not connect the two, realize that they are more likely to develop high blood pressure later in life. So they are at risk for hypertensive disease, cardiovascular disease later in life. It just shows itself during pregnancy for the first time. Thank you for that.
I said I'm an example of that.
Hello, how are you? My name is Melina Garcia. I'm the founder of United Children's Music Project in Hudson County. I don't know if there's anyone else from Hudson County. I'm usually the only one in all these conferences. Hi. So there's so many things that you guys have mentioned that went straight to my heart because I have experienced them all. I wanted to thank you all ladies for everything that you're doing and for inspiring so many people and doing such great work, as well as the organizers here. But one thing that I haven't heard, that I'm, as someone who also deals with families of low-income families, predominantly Latinos in Hudson County, and I serve kids from 3 all the way until they go to college. The young generation, the females, and when you guys were mentioning what's being done before they even become mothers, they are so frightened. There seems to be some type of video viral stuff where the fear of becoming mothers, everybody, like every one of those kids right now, they're afraid. They're afraid. In my generation, that was also true. It was different things. Everything was, women have to be, career first, right? So a lot of people in my generation, we were very driven to, attain higher education, doing all of these things, and always pushing motherhood until later. I always wanted to be a mom since I think I was born. And because of these influences, I also fell prey into this, and I became a mom at 30, okay? If I could do it all over again, I would be a mom by the time I'm 25, so that I will have enough time to have all the kids I wanted. I wanted to have more, but I didn't have the time. So when I talk to my daughter, who's 17, and all her peers in the same age group, they are all saying the same thing. I'm gonna die in childbirth. I'm not gonna be able to have a successful life. Oh no, I don't wanna be a mom. I don't see any, I've seen pushes or advocacy for when you're a mom or prenatal care. In Union City where I live, of course, we used to have a teenage pregnancy issue. So of course, there's a lot of advocacy for girls not to become pregnant, but there's nothing in between. So how do we, what is there being done so that young females understand, yes, you can get educated, yes, you can have a passion to be a professional, but the most important thing for any human being is to have a family. Nobody, in our dying day, moment, nobody thinks about a degree, right? Yeah. We all think about the people we love, our partners and our kids, number one, I think, right? So I always, as someone who loves children and always wanted to be a mom, when I hear young girls saying, I don't want to be a mom, oh no, I'm going to die and it's going to be this, I'm not going to be able to fulfill my life, it's very scary, because the same thing is happening to boys as well. So that was my question. What type of advocacy is there to prepare them not just physically, but psychologically? Because if you could be physically prepared, if you're not emotionally prepared, then you have all these issues with postpartum, et cetera, that you all have mentioned.
So I'd love to start with this, and I have a little bit of a different framing. Our organization is a reproductive justice organization, and that is based on 4 principles: the right to have a child, the right to not have a child, the right to raise that child in a healthy and safe environment, and the right to bodily autonomy. I have found that the teen population in particular, and I'm an 80s baby, and I feel like the the conversations that we had around sex and women's health during the time that I grew up have disappeared. And that's something that I have paid a lot of attention to. And so our organization is not a statewide fix, but I can say for our little space of what we're doing is the creation of a teen clinic. We have opened a maternal health center. There will be a teen clinic in house that will serve teens on a specific day of the week. That's something, and I'm not a New Jerseyan by birth. I actually grew up in Boston. And Boston had a very different model of care. And as a teen, there were places that I could go that I was safe, including in my own high school. And so there was a nurse practitioner that was our school nurse. If you needed birth control, she could write it for you. If you needed education, there was a place that you didn't need to go all these multiple different places and research to find it. I don't see that as much as the culture here in New Jersey. And so we're working to build that. So it's not an immediate solution. It's something that we've thought about for our strategic plan going into 2026. The teens that we have spoken to, just going to their GYN care, don't know what to expect, have reported very rough vaginal exams and don't know how to manage that. And that's not what this care should look like. So that's our little piece of the pie that we're going to work on. But I agree that it's an area that needs attention.
Again, yes, absolutely. Nationwide, when you look at the statistics, this generation is going to sound terrible. This generation is one not having sex, right? The way we in our past generations did. Is that TMI? Okay.
No.
The data is definitely there. But what we're doing within the consortia is we have 2 family success centers. And in those family success centers, we do have a program for parents and their children, teenagers, so they can have an open dialogue, right? My mother was a nurse. She was a midwife, never told me about sex. She said, "You're 19 now. You know what's happening." And I'm like, oh, okay. But okay, I'm 57. Now, the conversations that teenagers are having with their parents are different. So we help them navigate those conversations to have more honest and open conversations about, pregnancy and risk aversion and all of that. So that's happening in our family success centers that we have in Dover and Irvington. And we also have programs that we go into the high schools. And it's very small, and of course it's with only North Jersey, but throughout the continuum, this is something that you see that we're each working on. So continuing to bring that to the forefront and having those open conversations is really important. But again, it goes back to trust. Do you feel like you can have that conversation without retribution and without retaliation?
Yeah. I'd also point out our youth pregnancy prevention and sexual health programs that we all support. We have programs in both the high school and middle school in Atlantic County and in Cumberland and Salem. I'm looking at Lori to make sure I get it right. And Camden, thank you. And so actually, to my youth health program staff are here today because we knew that the perspective that they bring in, especially focusing, I loved the way that you explained your thinking on it. That vision of a life is part of what they're working on with kids, right? And helping their peers to think about, what do I want my whole life to look like? Not only about, condom use and STI and pregnancy prevention. We know, as everyone's noted, the teen pregnancy rates are like so low, and we're not seeing, so that's a good, right? But what are the things that we can do to help people feel safer? And we also recognize with the advanced maternal age that we're seeing, the health conditions that individuals are experiencing are different. So all of those are parts of the work that we have to do and the way we frame the work. But I think that joy also comes from listening to stories. We talked a lot, and it's been mentioned, the idea of the importance of listening to mothers in order for them to be safe. But it's also, when we do that, we hear the stories of safe birth, of confidence in birth, of, we've recently completed a scientific study with the maternal experience tool that the community developed, and we're seeing over 70% of the people responded said they felt strong or confident or supported. So being able to put that information out, and not only the data, but the stories that really help not only share with the community of people who may become pregnant, but with the physicians and care teams to say, these are the experiences that make people feel safe and supported, so that we're using that information in all of those ways. So,
All right, can we just thank our panelists and thank you all for staying?